welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Hello, and welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, a nerdy neurologist. I am so excited to join you all for another episode where we are going to be doing the year in review. There's so much exciting information that's been released about multiple sclerosis in the past year, and I certainly won't be able to cover everything, but I am super excited to have my amazing guest and super friend, Dr. Annette Okai, joining me tonight from Dallas, Texas. Welcome, Dr. Okai.
Thank you, Mitzi. I'm so happy to be back on the show.
Yes. Well, I know you're a regular on Brain Chat, so you know how this works.
Yes.
But I'm really excited for us to just kind of do a download of all the things or some of the top things that have happened, because we won't be able to do all the things. But some of the top things that have happened. Yeah, top things that have happened over the past year. But first, you know what happens when you come on Brain Chat. You have to tell us, a little bit about how you got involved in treating and caring for people with multiple sclerosis.
Well, so this story starts in residency. I did not consider MS at all because I didn't have any exposure to MS. But I had this amazing mentor who was an MS specialist, and he introduced me to the world of MS. And I just kind of took to it like duck to water, as they would say. I just found the field very interesting, amazing, and I was looking forward to everything that was going to happen, how it was going to grow. And fortunately, it just clicked with me, and that's how it got started. And I love it, and I've been loving it since that time.
Absolutely. And my story is similar. I also met an amazing mentor who introduced me to the world of MS. And like you, one of the things that I loved about neuroscience is that everything was not figured out down to the final detail and final receptor. I liked the idea that there was more to explore. And I was so right that there were going to be amazing advances during the course of our careers, right? We came out of training at the same time. And it's just been so great to see all the new options we have to offer our patients. Many of our patients are doing better. We still have a lot of work to do, but it has just been so exciting to see these amazing advances happen in real time. And that's one of the reasons I really got interested in neuroscience, because there was a lot of room for discovery.
Yes, the advancement has been amazing.
Yeah,
Very phenomenal.
Yeah. So let's get into some of these advancements, right? So we picked a couple topics that we're going to go through. Obviously, we're not going to cover every amazing thing that's happened in the field of MS, but let's start with causes, right? So one of the big difficulties, I think, with MS is that we don't necessarily know one cause for the disease. Even if you think about testing, we don't have an antibody that we can test for to definitively say someone has MS, like we do with other diseases like lupus or rheumatoid arthritis, etc. But there was a big splash earlier this year about Epstein-Barr virus, right? And so I want to talk a little bit about that. So we've always known that Epstein-Barr virus has been associated with MS, right? This is not necessarily new, but there was a new study that was published from the VA that gave us even more data suggesting that Epstein-Barr virus may be a cause for MS. And for those in the audience who may not know what Epstein-Barr virus is, it basically is a virus that probably about 99 or 98% of the population has by the time by the end of our lives. But in high school, we used to call it the kissing disease. So it causes mono. And so, when the kids were out for 2 weeks, it was because they were kissing, doing something they weren't supposed to be doing. And so it is most commonly known as a cause of mono. So tell us a little bit about that study and kind of what our learnings are from it, Dr. Okai.
So, as you said, it made a big splash. And the reason that it did was that this was a accumulation of 20 years of data collecting. And in
Mm,
MS, that is a long time. Most
yeah.
of our studies that we have go 2 years and then we start, extrapolating from there. But this was huge because it was 20 years in the making. And what that study showed us that among all the viruses that were studied, and there were several that were looked at, including CMV, herpes, and all the other viruses candidates that we could think about that were associated with demyelination or MS. Epstein-Barr proved to be the constant in all DMS patients, that almost all, I would say, let's not be absolute, but Epstein-Barr seemed to be the one that was the constant in majority of the patients. And why is this important? I think it's important because can it help us predict who's going to get MS? Can it help us then take a step back and intervene before someone does develop MS? I must say that Epstein-Barr is not the one singular cause of MS. This study does not suggest that. What this study suggests is that if we had to look for an infectious cause, we don't have to look too far because this is a common virus. The opposite of this study is that there are a whole lot of people out there that get mono or get infected with EBV that do not progress to MS. But the people that do progress to MS, now we can then take a closer look and say, okay, what made this person susceptible after this infection to get an MS? So this is a step, and it's a huge step because we have this longitudinal data in helping us unravel the cause of what's in the genome that make people susceptible to MS.
Yeah, absolutely.
Mhm.
So any step closer to finding a cause for MS or finding, potentially one of the triggers, I think is extremely important. I think the other piece is that could it potentially look or help us to figure out ways to either prevent or treat MS in new ways, right? People have talked
Mhm.
about things like vaccines versus EBV, and these are not things that are, going to happen tomorrow. But I think that anytime we come up with ideas about a cause, it also potentially opens a pathway to see if there are new treatment options or treatment pathways. And then ultimately, is there a way we can prevent people from developing multiple sclerosis if we identify all those factors? So I agree. That was very,
Exactly.
very exciting. I
Mhm.
think that, the other piece that's a little bit difficult, is because when people, hear data and, now everybody wants to go get tested for EBV. And,
Yes.
I think that we have to, take that data, and recognize that there's more work that we have to do, right? We know that's not the only cause because, as you said, the majority of the population has it and many people don't develop MS. So it's
Yeah.
a new pathway. But we got a little bit more ways to go to better understand kind of what that means in terms of treatment as well as prevention. So that was very, very exciting. So there was a
I
big
think
everybody was talking about EBV.
Yeah, I think one more thing to add is that for those who already have MS, I advise patient that that doesn't mean you should go and get tested for EBV. EBV may not have been your trigger, so that the information that we have right now, I cannot really apply it to those who already have MS.
Mhm.
But who knows? Once again, is there a pathway to say how can we treat people who are already diagnosed? But this is more for pre-diagnosis and looking for triggers.
Absolutely. So,
Mhm.
thinking about, so that's a great segue to the next topic we want to discuss. So, thinking about, how can we identify those who will go on to have MS? There's also been a lot of talk this year about radiologically or radiographically isolated syndrome. So there's also been a lot of talk about what we call an MS prodrome. So, we have people who have MS, and we know that there are certain risk factors, EBV infection being one of those, as well as their genetic markers, also geography may be involved, sunlight exposure, vitamin D, etc. But there's been this big talk about how can we find people in the earlier stages, and there's been several articles about the MS prodrome, which is kind of this period before people get diagnosed, where they may have multiple different symptoms that are not really specific, like headaches and other things, not typical symptoms of MS, but it seems like they start going to the doctor more often before they get diagnosed. And also, because we have more accessibility to MRIs, we've now had a larger group of people with what we call radiologically isolated syndrome. And those are people who maybe have another issue. Maybe they have headaches. Maybe they had a car accident and they had an MRI for some reason and it looks like MS, but they haven't had any of those typical symptoms of MS. And so early studies suggested that about a third of those folks would go on to develop MS. But what have we learned in the past year about radiologically isolated syndrome that may help us to better understand who may go on to have MS and who may or may not?
So yeah, so this was a big topic recently at one of our largest meetings, but it has been going on for for a while. But 2022 really brought it into focus at the beginning of the year. Talking about, like you said, people who go and get an MRI for a different reason, and then they end up with MS looking MRI and never had any symptoms. So there is a MRI a work group and a radiographic isolated syndrome work group as well. And the first thing is they tried to do was to put in a criteria for radiographic isolated syndrome. So not every white spot we see on MRI is a demyelinating lesion. They can be due to microvascular hypertension or diabetes. So the first thing was to establish a criteria to say what are the features on MRI that makes us say that this person has radiographic isolated syndrome,
Mhm.
indicating that they have some demyelination in the brain without clinical symptoms. So that kicked off the year, but it really culminated the end of the year in October at our as I said, largest MS meeting where what the study conducted in radiographic isolated syndrome, people identify that the MRI fits the criteria for
Mhm.
MS and it didn't have any neurological symptoms. And some of these people, I must say that they had multiple MRIs with changes and behaving just like MS, and they're walking around without any clinical symptom. Well, if you intervene at a certain point, you are saying, you look at this MRI, look like MS, you haven't had any symptoms, and we're doing follow up MRIs, and you're still having changes. If we intervene and put disease modifying therapy in place, can we effect a change in
Right.
that person? Because every time, as you know, Dr. Williams, when you have a lesion, that's brain tissue we are not getting back, right? And it accumulates over time. And at ECTRIMS this year, the study was presented that showed that intervening, if you are sure that this person have all the markers of MS on MRI, and they're behaving like MS but still not having clinical symptoms, and you intervene by introducing disease modifying therapy, you can actually slow progression on MRI that we see, and that is huge because
Yeah.
the standard of care is that no, this person have not had clinical symptoms. They do not meet the diagnosis of multiple sclerosis as we have it. So you just monitor. It's not recommended that you start treatment. But in the trial, we intervened, and we showed that it slowed down or stopped progression. Now, this is something that providers struggle with over time, because you're seeing this person, and
Right.
they're having new lesions all the time, and especially when you see active lesion or gadolinium enhancing lesion on MRI, as we call it, it really scares you. It's almost instinctive that you want to do something about it as a
Right.
provider, even though
Right.
the patient is sitting there and saying, "No, I'm fine. I haven't had any weakness. I haven't had any numbness or tingling. Of my walking is fine. My vision is fine." But you
Right.
know that this immune system is out of control, and
Mm-hmm.
it's causing more lesion and causing more brain damage. So to just sit there and monitor is sometimes difficult for a provider. But as I said, the study showed that intervening when they have met the criteria, you have ruled out all other causes, and the MRI fits an MS MRI, you can slow down the progression on MRI over time. So that was very, very exciting, huge. It was a late breaking news at the conference, and it really is going to push the needle earlier
Right.
in the MS spectrum, and that's
Right.
what we're hoping for.
So the goal is always to try to catch people as early as possible, So the diagnostic criteria, the way we diagnose MS has evolved over time so that, now instead of waiting for a second episode to happen, which could be 5 or 10 years after the first one, then we started looking at MRI, right? And so then we would do repeat MRI. And if the MRI changed, we could diagnose. And now you can diagnose somebody with one MRI if it has new and old lesions on it in different areas. So this is really, you know, um, important because what we're trying to do is to get to people as early as possible. Now, there's some people who will come to diagnosis and their first symptom just happens to be caused by maybe their first or second lesion and they don't have a lot of spots in the brain. But there's some people who have developed spots over years, and by the time
Mhm.
they get that one that sends them to the doctor with a symptom, they've already developed lots of areas of potential damage in the brain. So I'm really excited to, hear more about further results from the study and to see, what we can do to better serve our patients. So that was a really, really cool breakthrough that we heard about. So let's move on and talk a little bit about biomarkers. All right. So we talked about, causes, potential causes like EBV. We talked about, trying to diagnose people early, like radiologically isolated syndrome. I think one of the biggest areas that we struggle with is how do we monitor people over time? So the best tools that we have right now are the physical exam and the MRI, right? And certainly those can be helpful, particularly early on in disease. But sometimes, a patient will come in and say, well, I'm not feeling like I can do the same things at home. But when we do their exam after they're arrested and they've been riding in the car to get to us, they look the same, right? And we look at their MRIs, and sometimes after you accumulate a certain amount of damage, we may not be able to see very much that looks different. So, talk a little bit about some of the biomarkers. Particularly, there's one that we've been looking at for a while called NFL. It
Mhm.
was originally looked at in the spinal fluid, but obviously nobody's going to go back for multiple spinal taps to monitor that. So
No.
now we have a blood test to help monitor. And then talk a little bit about some of those new MRI techniques or new things that we're finding on MRI that may be a little bit more detailed that can give us some additional information about how people are doing once they're diagnosed and once they're on disease modifying therapy.
So I'll start with NFL first, which is a we can now measure in blood. Okay,
Which is
so
not National Football League, just for
not National
clarification.
Football League, neurofilament light chain
Right,
is what
right.
it is. Okay, so as you said, trying to prognosticate
Mhm.
is difficult. Trying to see who's going to progress, who's going to remain stable. It's still art form in the field of science, in the field of MS. But neurofilament light chain has come along, and is very promising. First, it's a marker of axonal damage. So what does that mean? It means that if your nerve is damaged, it releases certain proteins into the blood and CSF, and that's what we are evaluating for when we do the blood test. So NFL is one of those markers of axonal damage. Now it's non-specific in that regardless of what causes the damage, you can see it. But
Hmm.
in MS, it has found its place very high on the list as something that can help us, one, see who's going to have who's having a relapse. And I will just put a disclaimer that all of these functions are still, being looked at. It's not validated or generalizable at this time, but it's close to it. So one, it can help us see who's in the midst of a relapse, because if you're in a relapse, and that means there's inflammation going on, there's damage going on, we probably see an increase of NFL in the blood. Another way that we could use NFL is to look at it as a marker of treatment. So after you determine relapse and you start someone on treatment, does the NFL remains high, or does it goes down to a level that indicates that axonal damage is now less? That's one way that we can also look at NFL. So looking at it in determining if a relapse is occurring, or if a response to our disease modifying therapy are two of the main places that we are
Hmm.
looking at NFL for.
Yeah. And so I think it's also important to note, as you said, there are some groups that are developing or have developed commercial tests where, like, a neurologist in practice can order this, but for the most part, this test is not something that's widely available. So you can't just go to your neurologist and say, "Hey, can you run an NFL?" Right?
Yeah.
So these tests are still very commonly used in research settings,
Yes.
but there is a move for more commercial tests where people in the community will be able to order these outside of scientific research studies.
Yeah, and also to point out that, as I said, NFL may be elevated in other disorders or disease.
Hmm.
So, someone who has something else going on, some other inflammatory process,
Hmm.
that it may skew the results. So, once
Right.
again, it's not a widely used commercial test. It's out there, but it's still finding its place
Right.
per se.
Right. And I think
Mhm.
the other piece is that, again, with most of MS treatment, it would always also be individualized. So it would be looking
Yes.
at that person's baseline levels, right? Knowing what your levels are, and then comparing those
Right.
after treatment, et cetera, to see how they fluctuate or go up and down. So it's
Mhm.
not like a exact measure, let's say like a hemoglobin A1C, which people have with diabetes. We know that if that's over a certain number, you're in trouble,
Yeah.
right? Versus
Mhm.
if it's under a certain number, then usually good. So
Yeah.
we still have a long way to go, but it's very promising. And as you said, I think very exciting, just to look at other additional measures we can use to monitor how someone's doing over time. And so
Mhm.
I'm very excited about that, as well as some of the other blood biomarker tests that are being looked at. So let's switch gears and talk a little bit about MRI. So, MRI has been around for, I won't say forever, for some time. It has really revolutionized our ability to diagnose multiple sclerosis as well as monitor it, but it has some limitations. So let's talk about maybe some of the newer things that are being looked at to help us better understand how people are doing with MS.
Awesome. So MRI, like you said, it's our go-to tool for
Hmm.
diagnosis, for monitoring. That's our most reliable biomarker, right? But there are still some limitations. And I'm sure you have multiple patients who have said, well, Dr. Williams, I'm feeling bad. I feel like I'm getting worse. And you're telling me my MRI is stable. What is going
Absolutely.
on?
Hmm.
Does that mean that there's nothing wrong with me? It's all in my head? No. What it means is that there are other underlying biology that the MRI cannot pick up all the time.
Right.
And so recently, and this is still in research, is not ready for prime time yet. But what we are seeing is that in certain forms of MS, we have the relapsing form and the progressive form, and people go for years. Now people are living longer. You know, what is it that is occurring that manifests itself as progressive or even other things? So, what we have found out, and we're still looking into, is that there is chronic inflammation. So, even
Mm.
though we are not seeing, inflammation like we do with relapsing patients, patient still have inflammation long after the acute ones have been taken care of. So we now have what we call slowly expanding lesions. We have paramagnetic rim lesions. Those are terms that are coming into the lexicon of MS specialists, telling us that there's inflammation is chronic, and sometimes it's away from the site that we initially thought it was, and it can be diffused throughout the brain.
Mm.
And one way that we can try to look at it non-invasively, so it's MRI. How do we refine our MRI measurements that we can see these slowly enhancing lesions and bring it to make it applicable in a clinical setting? As I said, it's mostly in research, but we want to make it in a way that the person reading at our off-site MRI center and sending it to the physician, they may be able to understand what is going on with someone who may not be showing a classic sign of a relapse, but is progressing.
Mhm.
Okay, and so when we also look at the biology, and I'm going to go a little bit more scientific and talk about, we have our immune system which adapt to certain situations, and then our immune system where in which we were born and have certain cells to help us. So we call that the innate immune system, that which we were born with, and the adaptive immune system that respond to external things. So when we look at the cells in our immune system and where they are in these two compartments, what are they contributing to? And short of going in and taking you apart, we can look at the MRI and look at certain things on the MRI and say, oh, the innate immune system may be contributing to what we see in terms of the slowly enhancing lesion or the paramagnetic rim lesion. What does that mean in terms of the progression of this patient? What does it mean in terms of the chronic inflammation? And when we ask those questions, then we can target, okay, so now we see chronic inflammation is not as apparent as someone who's having acute inflammation and having relapses. Our target now is going to be chronic inflammation and see if that can translate into helping this progression that we see that is independent of relapses. That's another phrase that we have, right? Progression independent of relapses. How do all of those things come together so that when our patients come and say, my MRI is stable, but I feel like I'm progressing or I'm still having symptoms, we have an explanation, and probably in the future we can tailor our disease modifying therapy, our treatment plan to what we are seeing.
Yeah, I mean, so it has been very fascinating to begin to understand what's going on under the surface. And when I talk to my patients about MRI, I always tell them the MRI basically kind of gives us a peek of what's going on under the hood, but we have to recognize that it has limitations. So I compare it always to looking in a mirror. You've got your regular bathroom mirror that you look in, and then you've got your fancy mirror from, Bath and Body Works where you can see 10 times the magnification. So as our
Yeah.
techniques get better, we get closer to that 10 times the magnification mirror so that we can see, the very small things that are going on under the surface. And also it gives us an idea of what's going on with the person or individual that's sitting in front of us, but also more information about how our treatments may or may not be working and something else to monitor to tell us if our treatments are or are not working. So I think it's very exciting that we're getting these new terms, that we're trying to better understand what is going on, particularly in the progressive part of MS, because we used to think of relapsing MS and progressive MS as in two different buckets. But what we now realize is that there's a lot of stuff going on at the same time. And so it's kind of like that room that looks messy before you clean it up. But we're learning more and more, so that we can be able to sort out, what is really going on with people, particularly when the measures that we have right now are a bit limited. But they've gotten a lot better than when we started training. So
Exactly. Exactly.
I remember when our images for the cervical spine first came out. There are these new images. Well, they're not new now, but we call them STIR, where we can really see lesions. And I remember when we didn't have those. So it's coming. It's coming.
Yeah.
Things are progressing. So
But I
now,
also
go ahead.
think one thing, sorry for that. I
Yeah, go
also
ahead.
think when we start to identify these things, then it leads us to more target for intervention,
Yes.
right? So now that we are seeing that inflammation is chronic, even
Mhm.
past the relapsing phase, okay, what is driving that chronic inflammation? And then
Right.
we look at the cells that we see around those lesions, and like, oh, okay, these cells are kind of new. We didn't think about them as being an inflammatory cell. Now we're seeing them
Yeah.
causing inflammation.
Yeah.
And we can say, wow, okay, that's something we can target. And then we can develop more treatments to
Right.
target those cells, because what we are doing now, it's did not cover chronic inflammation,
Mhm.
and now that we are seeing it, then we can target and
Yeah.
intervene with
Yeah.
different types of molecules.
Yeah, yeah. I mean, it's fascinating. Like there's always, literally always something new going on in the field of MS, and we're learning more and more every day. So we talked a little bit about, biomarkers, right? Measures that we use to determine how someone's doing in the course of their MS. Now, let's talk a little bit about this. Has been an interesting topic. There've been a couple of, topics going on surrounding disease modifying therapy or DMTs, right? So there's kind of the high efficacy early camp where people suggest that we treat people very early on with very effective therapies to try to kind of stop the mess in its tracks, so to speak. And then if we need to back off of therapy later, we do that. And then there's the kind of escalation therapy camp where people start with, less effective medicines, less side effects. And we're not going to go into that, but that's just an example of kind of some of the talk about treatment. There's several large clinical trials that are looking to examine which approach may be the best. And there's some data already from other smaller studies suggesting that, high efficacy early may have a bit of an edge over the other approach. But another big topic in terms of treatment has been discontinuation. So I remember in training when we used to talk about how MS burned out over a certain time. So people just got a certain age and it was just thought the MS wasn't doing anything. And that may have been partially because the MRIs we were looking at look the same because we did
Yeah.
have better techniques. And then people seem to look the same. So people just kind of determine MS is not doing anything. Maybe we shouldn't do anything about it. And so, as we get older and more mature, There also is this big question of what we call immunosenescence, meaning as we age and, our joints and other parts of our body age, our immune system also ages. So we always have to weigh the risk versus the benefits of different types of medications, right? We want people to be treated for their MS, but we certainly don't want them getting lots of infections or getting sick because maybe the treatment is too strong for their immune system. So let's talk a little bit about some of the studies that have been discussed this year about treatment discontinuation. When do you stop therapy? Should you stop it? What should you do?
So I say that question is still up for debate. There
Hmm.
are several studies going on worldwide for that. And I say it's the golden years of MS. We're in a great time in terms of our field with all the advances that have been made and we're still making. We are seeing more medications, more targets for intervention, and so people are living longer. We haven't, I wouldn't consider us old in the field, Mitzi. We're still young ones, I would think.
Absolutely.
But
I in no way, so my target for old gets higher and higher.
me too,
The older
me
I get, I
too.
remember a time when I thought 30 was ancient, and so now I'm like 90. I mean, 90's old. Anybody less than 90 is, pretty young.
Yeah.
So I definitely agree with you there.
Definitely, I'm totally on that. But when we were in training not too long ago, I remember that age 40, we saw people really debilitated,
Mm,
people in nursing homes, and
yeah,
then dying from complications of MS. And
absolutely.
now we have the majority of our patients, people with MS, living way past 70, 80. And that this is amazing because they are not dying young. They are not 50, they are not 40 in a nursing home with 80-year olds. But with that success, where we have people living longer, that brings more questions because we're like, okay, we have not had this situation before where we keep people on therapy for 30 years, 40 years, going knowing that we our first disease modifying therapy was 30 years ago. So
Yeah.
with that, then we have to look at the immunology. Yes, as people age, the immune system also age, and our therapies are targeting the immune system, especially trying to keep it under control and and by with most of our neuromedication lowering some of those cells, and like you said, expose that can lead to increased risk of infections and all of that.
Hmm.
And so the question is, as the immune system age, does MS fizzle out? Does
Right.
because we're not seeing any more inflammation, does that mean that the disease has entered this quiescent period? That is still a question to be answered, and that's what most of these discontinuation therapy studies are looking at. So in the U.S., it's called Disco MS, and then there's two in Europe that were presented at our conference, but those have not closed out yet. And what was seen, I think the preliminary data from Disco MS is that I'll take a step back. Is how do we identify these people, first of all?
Hmm.
How do we
Hmm.
identify who we are going to stop? And while there isn't a true criteria that's used across the MS world, there are a few general principles. And those
Hmm.
principles are, if someone have been stable on treatment for over 5 years without MRI changes, without relapses, and they're over a certain age, there's a debate, is it 55, is it 65? I'm not sure myself, right? But
And just for
over,
the record, 55 is not old.
okay, 55 is not all. Yeah, we'll push it. We'll push it to 65, 70.
70, more like 75.
Okay, okay, so okay. So but after this period of time where there aren't any MRI activity, no clinical signs of progression, and no relapses, those people may be a candidate that you can take off therapy and just observe them. And in the disco MS study, there I think 7%, and please don't take me on this, but it was either 7% of patients or they were 7% more likely to have relapses compared to patients who stayed on therapy. But I think the take home point from that treatment is that yes, there are people that we can safely take off treatment and they remain stable over time. It's just trying to tease out who those people are, and there are different nuances as okay, so what did they look like before? If you look at the age group, if it's on the younger side, and younger being 55 and less
Mm-hmm.
versus those 65 or less, you see, those are the people who are more likely to have some relapse activity versus people who are on the other side of the bell curve. But there is still more data to be looked at. And
Mm-hmm.
so it's not generally accepted yet to just take everyone off therapy after a certain time and they haven't had any relapses, because we are still diagnosing people, and there are people in the 60s who are still having
Absolutely.
inflammatory activity.
Mm-hmm.
While it's good to know that information, we still need more studies that tells us, okay, what determines who's going to relapse or not when you take them off therapy. And probably biomarkers will help us in that point as well. But it is a big question. And especially in the US, I mean, the Europeans are still looking at their study, but look in the US, when you reach Medicare age and you look at the cost of drugs and you look at what they burden on the patient, it comes into play as well. While economics shouldn't be a driving factor in how we treat patients, we
Mm-hmm.
cannot deny that it plays a role as well. So lots of questions still to be answered, but there is a trend that after a certain period of time, there are some people that can be taken off therapy and monitored clinically and radiographically off therapy to see if there are any progression.
Absolutely. And so, again, we want to do more good than harm. I think
Mhm.
the other piece is that, we do a lot of work focused on different underserved populations in the multiple sclerosis community. And I would dare say people over the age of 55 are very much underserved in terms of our research, because most of our research studies cut off at 55. We
Yes,
have some of the newer trials that are looking at 65, but we really don't know in controlled settings what happens to people over the age of 55, just the natural history of MS. So I think that this is very exciting. We need to study this in a um, you know, um,
control manner.
controlled manner. So
Yes,
I'm also excited to see what will happen with the European data, if it will confirm what we saw in the US data.
yes,
But I think that these are questions we need to answer, and we need to make sure that we're not leaving people out, because our patients with MS are living in their 60s and 70s, and some of them very independent. And we don't want to just stop treatment across the board, but we want to make sure that what we're doing is actually helping more than it's hurting. So thank you for
exactly.
that. Yeah. So we
Exactly.
got
But
to,
I think, yeah, one thing I also need to add is that while we are talking about underserved, it's hard to for sponsor to change the age. Even the newer
sure,
studies that are going on,
sure.
55 is still the cutoff, and then we go
Yeah.
back and then we do retrospective studies, which we retrospective review, not even studies, which
Yeah.
we know aren't the best for getting data because it's open to a lot of biases. So
Yeah.
definitely underserved, definitely needs to be looked at because like I said, there are people who are still having inflammatory
Mm-hmm.
activities in their 60s. You know, how do you
Exactly.
explain that and say, well, you're 62 or 65 and, let's take you off?
Yeah. Yeah.
More
So
questions.
absolutely. Every time we answer one question, we have more questions to ask. And so we've
Yes.
got a few minutes left. So we want to talk about kind of the future and what we're excited about. So, talk a little bit about this new class of therapies called BTK inhibitors. There are about, I think, 4 or 5 that are in the works now. But just give us a
Five,
rundown.
six.
5 or 6. Just
Yes.
give us a quick and dirty rundown of what those therapies are and kind of what we've learned about some of the trials that have involved them.
So this is an exciting molecule, BTK inhibitors. It's a long Bruton tyrosine kinase. It's an enzyme actually. So this will be the first enzymatic treatment for MS,
Hmm.
if approved by the FDA. But it's an enzyme, and when you have enzymes that are being affected, you have downstream effect. But the inhibitor of this enzyme is what many companies are looking into. It affects a lot of activity when it comes to B cell in terms of proliferation, in terms of maturation, in terms of how the inflammatory cascade go about. But I think what is exciting about BTKIs, the molecule, is that there has been what is seen as the potential to actually work in the central nervous system. So there's a brain penetrance, so it goes in and it affects, like I said earlier in the show, the adaptive immune system, which is what most of our other therapies are looking at, and also the innate immune system. Now, once again, it's still not yet approved by the FDA, but if the cells that we have identified in the innate immune system contributing to chronic inflammation and to the inflammatory cascade as a whole holds up and these molecule actually affects them, then we are going to have a molecule with dual mechanism, and that will
Hmm.
be exciting. So the studies are just starting to read out and lots going on. So all of these things still in the research realm, is not yet approved, and we're still answering those questions. But I
Hmm.
am really excited if we have
Yeah.
something that will work both outside the central nervous system and inside the central nervous system. If it can target chronic and acute inflammation, that
Yeah.
will be very good for our patients. And looking at the different types of disease phenotypes, it will be a game changer because it will move across the spectrum of our MS patients. So I'm
Hmm.
really looking forward to what those studies shows, and the effect it has, and what it can do for our patients.
Awesome. Well, this has been an amazing discussion. I am feeling extremely nerdy as I'm getting excited about the central nervous system
I know,
penetrance of
right?
medications. But it's been an amazing conversation. I am also excited about new classes of therapy. As you know, the changes in MS, just even in the past decade, have been astronomical. Like, we've just had
Mhm.
so much change in terms of what we're able to offer, how our patients are doing, and I look forward to even doing better than we have in the past. I think I am particularly excited next year for reporting out data from the CHIMES trial, which I'm super
Yes,
excited about. It is the
yes.
first clinical trial focused on Black and Hispanic people living with MS, and we just will be closing our first year of data at the end of this month. So I'm very excited to see what those results will show. Again, to help us to better understand other underserved populations in the MS community. And with that, I want to thank you so much, Dr. Okai, for coming on the show, for offering your wisdom, talking to everyone about these very complex topics, but making it very plain for our Brain Chat audience. And I look forward to doing this again sometime soon and talking about even more new advances in the new year. Thank you
Thank
so
you for
much.
having me. It was a
Absolutely.
pleasure to be here and always a pleasure speaking to you.
Awesome. Well, thank you everyone for watching Brain Chat, and we will see you again in 2 weeks. Merry Christmas. Hope you had a wonderful Christmas and Happy New Year.